the final speaker for this morning. He obtained his medical degree in Siriraj Medical School in Mahidol University, Bangkok, Thailand. He had his orthopedic residency training in the same university hospital. He had his fellowship in sports orthopedics at the Technical University of Munich, Germany. He then went to University of Würzburg, Germany for a fellowship in shoulder surgery. He is currently affiliated in orthopedic surgeon in Thammasat University in Thailand. He is a former director of the orthopedic department and head chief of the sports medicine unit in Thammasat University. He had presented, authored, and won several awards for tons of publications. Ladies and gentlemen, it's my honor to present Dr. Bancha Chernunjit, Professor Bancha Chernunjit.
Thank you. It's my honor to be here and see my old friend Tony. So thanks for the organizing committee, and so happy to see our old ex-fellow Soy Lawrence. Yeah. So now we have many new fellows from Philippines. I think now it's number one after Soy. So many in the queue. Thank you. And I found that the Filipinos and Filipinas are very nice. Okay, I'm talking about the, thank you, Claire, for your presentation, very nice. So I will now not talking about the details of the rotator cuff. I just focus in the practical point. Okay. So thanks my fellows. I have Thai fellows in the back. Actually, he looked like Philippines yesterday. Yeah, Dr. Kong, yeah, he's preparing the talk, and CJ, he's now my fellow, and Kat, yeah, Kat, she's from Mindanao, right? And another one, Dr. Saka from India. So Saka is not coming, he's very lonely now, and very sad because of visa problem, cannot come to Philippines. Okay, so today we're talking about the rotator cuff. Actually, there's many definitions for the massive rotator cuff tear, but commonly used is the definition by Cofield and Gerber. So the massive means you have at least two tendon complete disruption. Okay, and the size it depends. Nowadays we use the numbers of tendons. And look at the rotator cuff. This is supraspinatus, infraspinatus, right? So for the massive, you can have a big holes like this on the top of the shoulder, okay? So that you loss of the compression and it have a big holes on the top. So that's why it's proximal migrate due to the deltoid. Okay? When we talk about the massive rotator cuff, we should first classify whether it's repairable or irreparable. So that's very important because we need to discuss with the patient that he can repair your tendon or not. Okay? Most of the massive cuff tear, I think in our country, I think also in Philippines, they come really late. They come really late and they tolerate very well. And I heard that your reimbursement for the shoulder is not good comparing to the hip, right? Your hip, you reimburse nearly 100%. For the shoulder, it's not so good. So patients don't need shoulder for walking. So that's why they leave it and come to see us very late. So this is the way you need to, when you see the patients for the massive cuff, you look at the X-ray, always X-ray. Sometimes you skip to do MRI, it's too early. Because X-ray can tell you a lot. If you see the X-ray like this and you have the Y space on the top, like this, you have good center, more than 6 millimeter. Most of the time, this patient can be repaired. Even the cup big size. So I think X-ray is quite important. But if you see the X-ray proximal migration, there's no space on the top. There's some acetabolization. Those patients, I think, is not repairable. X-ray is quite important. So the next one is MRI. MRI, you look at the muscle qualities. If the patient have big tear, you see on the right, it's big size, big gap, but the muscle quality is good. So this type of patient also can be repairable. Okay, you can relieve the scar and then you can reduce it back. Okay, so don't forget look at the X-ray and also the MRI together. Do not skip the X-ray. But if you see the X-ray like this, you see the patient have proximal migration, no space on the top, no center, and the muscle is quite atrophic change, supra, infra, or supra subscap, like this. Gutalia less than 3 or 4. 3 sometimes repairable, but 4 most of the time you cannot. Okay? And also the retraction to the glenoid level. But the retraction, as I told you, retraction, I think the quality of tissue is more important than the retraction. Because some traumatic injury, the retraction is really far because it's retracted, big gap. But if the muscle quality is good, don't give up. You can repair it. Okay. So examination, you need to classify is this the post-low superior or is this the antero-superior? Okay. The post-low superior is more popular. Supra plus infra is more popular and easier to repair and less pseudoparalysis. Okay, but if you have the antero-superior, it's worse. Okay, worse prognosis, and you have higher chance of the pseudoparalysis. Okay, so this is the classification by Dr. Philip Collins. And don't forget the AC joint and the bicep. Okay, I always palpate. Always palpate. These are the two things that you always miss. And X-ray sometimes cannot tell you everything because many patients have AC joint arthritis, but no symptom. You don't need to do anything. Okay, so check the AC joint and also the bicep all the time, especially the bicep. Okay, because this is one of the causes that after surgery the patients still have persistent pain. So these are the treatment options. You see, 11 options. So you always start from conservative first. Okay, except traumatic cuff tear. Traumatic cuff tear, I will not wait. We do the surgery as soon as possible because if it's too late, yeah, you cannot repair it. Okay, because retraction, scar formation. So the timing for the traumatic is about 3 months. Okay, more than 3 or 4 months sometimes it's not easy. Okay. So let's talk about the treatment option one by one. So three things we need to concern: the patient factors, rotator cuff factors, and the surgeon factors. The cuff, as I told you, right? The numbers of cuff tear, retraction, and also the muscle quality. And patient factor, the age of the patient, demand and arthritic change or not, patient expectation. So you need to discuss with the patient because many patients are very stubborn and poor compliance. Yeah, these kind of patients you may fail after the surgery. And the last thing is the patient surgeon factors, okay, surgeon experience and also the how they train, right? So non-operative treatment always the first line, right? I think many patients, like Claire said, a lot of cuff tear can treat conservatively. Yeah, they have big size tear after you do steroid injection. Steroid is not that bad because many patients scare when you do steroid injection. I don't know how about Philippines, but in Thailand, the media, they sometimes they blame the steroid a lot. So people scare when you trying to inject some white, inject the steroid is white, right? So when you see, but always ask, what is that, doctor? Is it steroid? They say, no, don't inject steroid to my shoulder. How about it in Philippines, Tony? I don't know. That's okay with steroid, right? Okay. Like those. Yeah. Yes. So steroid also we need to try first. Even in the patient with cuff tear, in the literature said if you have cuff tear, inject steroid did not change the prognosis of the healing. Okay, so you can try the steroid injection in the cuff tear, especially in the degenerative. Okay, and also don't forget to do the stretching exercise and strength exercise of the periscapular muscles. So I did a lot of injection in the clinic: AC joint injection, subocciput injection, and bicep injection. Okay, so about half of my patients they're doing well, right? No need surgery. Okay? And also I many patients' pain is because of the stiffness. impingement cuff hair always coming with the stiffness. So after injection, the patient will have better motion. When they have better motion, pain relief, okay, inflammation subside, they will be good. Okay. So we try to do the exercise, stretching exercise to gain the motions. So several studies show that the conservative treatment improve the result is about nearly half, 40% of them were doing better. Same like my patients. So this is 78 years old patients. Look at the films. Okay, she has a lot of underlying disease, have heart disease, she had the stroke, also renal failure, right? So this patient come with shoulder pain. What do you do for her? 78. So I treat her with steroid injections. Okay. And I follow her. This is 5 years. You see, just no loaded cuff, just quite happy. Yeah, she can have a really good balance. Okay, no complaint. This 5 years already. So the next option is to do the conservative surgery like acromioplasty or tubuloplasty, AC joint resection, bicep tenotomy. So these kind of patients will be the patient that it's not a good candidate for the repair. You can do some conservative surgery because this is easy, right? Just cut the bicep, clean the spur, right? And sometimes the patient quite happy. This is my position. We discuss with Claire. Claire, you prefer the traction position, right? Because it's in Korea they always do like that. So for me, I prefer the rotator cuff and my shoulder surgery like proximal humerus the arthroplasty in big chair. For the instability, we do the supine traction. Okay, you can look in my article. The supine shoulder arthroscopy is quite convenient. Patient can do like OPD surgery and go home if you have a good anesthesiologist, because you don't need to go like lateral decubitus, and you have less gravity effect because you do lateral decubitus, the arm always dropping down. You need to lift up, but for the lateral, the arm dropping to the back. So you have more space in the front. Okay, you can try. Okay. So this is my photos routine photo for the rotator cuff. We always have about 4. If we have bicep surgery or subscap, I have 5. So that's maximum. I never have more than this. Okay. The benefit of this chair is that you can move. Sometimes you can, if you want to put anchor here, you can rotate. Okay, proximal. If you want to put in the front, if you want to put anchor in the back, you internal rotate. So that's the benefit of this big chair. Okay, for the lateral, you cannot move that much. Okay, so these are the pathology spur that you need to know: the irregular spur, the heel spur, and the heel spur. This is from my article. So if you had this type of the spur, you should remove it. Okay, like this. I always put the caudal tilt 30 degrees. You can see the spur very well. If you have this sharp spur, don't leave it because you always have problem like dorsal side tear of the rotator cuff. And this article from Habermeyer, they did the tubuloplasty. Instead of cleaning the roof, because they want to preserve the CA ligament, they're cleaning the tubuloplasty. Okay. From this study, he found that the patient had better outcome after the surgery. And this is the long-term study of the tubuloplasty. Yeah, they have the very good scores after the surgery. But it's not popular, the tubuloplasty. Another thing that you can do is the bicep surgery, bicep tenotomy or tenodesis. Okay, so distal clavicle AC joint arthritis. Yeah, if that painful and big spur, I clean it using the arthroscopically removal of the distal clavicle. So but you should not remove it more than 8 millimeters. If you move it more than that, you will detach the distal, the AC ligament from the clavicle. Okay, from this article, they found that debridement result is pretty good, 83%. Another article, debridement show the improve in pain and ADL after the surgery. Don't jump to repair it right away. You need to do a good release first. So that's the very important concept. Okay, to do the cuff repair, you need to debride and do the release okay, and don't give up. Like this. Yeah, even you have a big size tear, you need to know where is to, like Claire show you, right? You need to know where to put it, like apex reduction or margin convergence, something. If you put it the wrong way, you have too much tension. Okay? So this is a concept of the repair. Okay? You need to have free tension. We must always start with the release first, okay, until we make sure that it's not the cuff is freely movable. Okay. For the anterior part, like I doing subscap, I will release the rotator interval, release the coracohumeral ligament, and define the coracoid. Okay. So that is my way of the release. I think that is the most very important step. Yeah, before I'm jumping to do the repair, I clean it, I stop bleeding. You need to have very clear view before you start to repair. Don't rush to do repair, because there are a lot of bursal tissue bleeding and your view is not clear. So you will be struggle and your operation will be long. Okay? So I think I take my 50% of repair, I think 60% for this step, cleaning, stop bleeding, make it clear before starting to do the repair. Okay? And sometimes I need to release the inferior capsule also if the patient has stiffness. Like this, we call this rotator cuff mapping. See, you need to have a good mapping. If you put it the wrong way, okay, like this way, you see, it will be too much tension. Okay, you need to do it in the right way. And interval slide, I think I stopped doing that because supraspinatus and infra, you should not separate it. It brothers, you know, you need to put it together. Release it from the groove, release it from the coracoid, but don't separate. You cannot do the end-to-end attachment. Okay, most of the time you need to do like diagonal reduction. Okay, most of your cuff, massive cuff repair. Okay, and this the question I'm asking you, Claire, about the knot tying. Okay, this is very nice video. You see that the knot tying. You see the vessel. Vessel cannot pass through this knot tying. Okay, it's like strangulation. So that's why there's a report of the musculotendinous tear. Okay, nearly 50% of the cases. Okay, like this, you see, nice attachment of the cuff, but torn proximal to your repair. Okay, and I did this study comparing the knot tying and knotless. Okay, we found that the pressure distribution for the knotless is good. Okay, and you have less strangulation at the medial side. Okay, but less strangulation also sometimes you have problem because the healing on the medial may not good. Okay? So these patients I discussed with your boss, Dr. O. Yeah, you see that is nice from outside. See, nice suture distribution. When I look inside, I didn't tie the knot. You see that? There's a gap underneath. But you look at the back, you see that the two anchor in the back. That's nice attachment. So I want to see that not tying and knotless. Okay, for the medial side. So that's why I changed my mind. Okay, I stopped doing knotless. I do hybrid. I tie some knots. Okay, not over strangulation, not every knot, but some of them. Okay, and then distribute the suture. You see in the back here, nice attached. For the front, there's a gap underneath. Okay, even outside look nice. Okay, so this is our technique. It's already published. You can, I think, publish next month. Okay, our hybrid technique. So thank you, Kat. Yeah, you make a really nice diagram that look really confusing. Okay, she tried to do that. So one hose of suture of the cuff, you have more than one suture. Okay, so you will have less problem, less cuff trauma. Not one hole, one suture. One hole, maybe you have two sutures, three sutures. Okay, and you have less trauma, and you make the gap between each hole wider. From the literature, if you put it closer than 5 millimeters, the problem is you make it strangulate. and you can cut through, like you dot on the paper, right? If your dot is too close, you make a dot on the paper, it can cut through. So the distance between the suture should be about 7 to 8 millimeters. So that will be safer for the medial cut through. Okay, just from the literatures. So this patient had the massive cup tear for years. You look at the films, it looked so bad, right? The retraction to the grima level. There's a subscapularis tear. But look at the cutalia. Cutalia is not bad, right? So even he has the big size tear. The cutalia of this one, this subscap and infraspinatus look so good. But supra is about 3, right? Muscles and fat equal is 3. There's 2 options for you, the cuff repair or supracapsular reconstruction. But supracapsular reconstruction is not good for the massive subscap. It's good for the supra alone or supra infra, right? So you see that I did a lot of release from the coracoid process. We call this triple release, okay? And make sure that your tendon excursion is good, okay? Then we put the anchor in, yeah, like that. For subscap, it's challenging because your working space is very narrow. You have coracoid and conjoint tendon in the front, right? And in the back, you have glenoid. So I start my subscap repair first, and then do the hybrid repair, okay? Like that. You see that in the front, that is a conjoint tendons, right? So this is a hybrid. So I do some knot tying, some I do knotless, okay? Good. And then we do the lateral row repair. And we share the anchors, supra and subscap. We can share together, okay? So you don't need to put, this is supra, right? And in the front, that is subscap. Okay? You see that we share the suture from subscap to supra. So for the lateral row, you need only 2 because you're sharing the anchor. For the medial, you use 3, 2 for supra, 1 for subscap. And I prefer to use the triple load because the cost in Thailand, double and triple is the same. Okay, so the patient don't need to pay that much. Okay, and that is the MRI of the patients, and this cutalia is also getting better. This is about 2 years after the surgery. Okay, he's the farmer, so he's worked really hard, and the function is pretty good. Yeah. So don't give up even the very big size tear. This is also another big size tear. Yeah, and nice healing. This is traumatic. Yeah, but the traumatic, don't give up because most of the time this have a good quality. You see the retraction of infraspinatus, supraspinatus, and pseudoparalysis. Okay, but you look at the here, this one, you see, this is cutalia 1, very good supra, good infrastructure subscap. Even the retraction is so far to the head 3, you see, don't give up. So I discussed with him, you have 2 options. First, I will try to do my best. Even he is 70. Not every 70 you need reverse shoulder toplasty. Okay. So now you don't have reverse in Philippines, right? Yeah. So you have no option. So you need to repair it. Yeah. Okay. So that is the after release. I take about 45 minutes for the release. I take about 20 minutes for the repair. Okay. So the repair is very fast because one hole I put about 3 or 2 sutures. So it's very fast. So this is after the repair. And you see that this is the before and after, right? The pseudo just a better external rotation and no more pseudoparalysis. And look at the MRI, comparing before and after. Okay, this is before and this is after. So the healing is pretty good. Yeah. So I follow him now 2-3 years. He's doing well. So how about the loose suture? Many times we do the cuff repair, but when the patient start to do rehab, this suture is getting loose. from the study, they found that the suture getting loose over time. Okay, so like this. This is another article published in the arthroscopy. So when you do the cyclic loading, 100 cyclic loading, the suture that looking good at the beginning is getting loose, and you lost the effect of the footprint compression. Okay, so even the tape of the suture is getting loose. So MyTech, they have the new product, this Dynacord. It's very interesting because your suture, even it's getting loose over time when it's soaked in the normal saline or in the blood, it's getting tighter. Yeah. So I have tried this. Like look at the pictures. Yes. Yeah, you see that? Over time, this suture, this 12 ounce, 18 ounce, the loose suture can be tightened again, right? But this one is a typical suture, it's getting loose over time. Yeah. See that? It's quite interesting. I think that this is it's like a contractile suture. Okay. So this is from the study. It's getting tighter after the over time. I show you one patient. I have some experience with this Dynacord. So he has a massive supraspinatus and also the biceps problem after the compressions. Okay. So we put the ankle sutures, 2 on the medial side. Okay. And then we pad the suture after doing the apex reductions. Okay. And yeah, that's the Dynacord. You see that, the blue one? Yeah. It's look thicker than the others. Is this another example? So this is a medium-sized cuff tear. Okay. After performing the microfracture, I put this the MyTech anchor. So it's Dynacord. First we tap, and then put the absorbable anchor. This one. This one is you have this one in Philippines now, Tony? The Dynacord. Yeah, you have it. Okay. Okay, that one. You have double load Dynacord. So I add another one into, you see? Now we have triple load. We put the suture into the suture. You can change double load to be triple load. Okay, and then we pad the suture. Did you see that? One hose, I have 3 sutures. See? So then I choose tying the suture. Not every sutures, and some of them I cut, some of them I pass to the lateral low. Okay, like that. You can save the time also. Okay, then doing the lateral low. If the patient have osteoporotic, I tend to put my ankles close to the bicep groove because they have better bone qualities, and another ankles close to the posterior cortex. So try to put the lateral low as wide as possible. You have better area, more area of the suture compressions. So for the partial repair, yeah, in some patients we cannot make a full coverage. From the literatures, the partial repair is not bad, and most of the patients getting better. This is 65 years old, just massive, poor quality. Look at the cutaneous, right? It's 4 for the supra and also the infraspinatus. So this patient have the very poor cuff tissues. So I doing the release. You see that? After I do the release, that's colloquial process. Okay, cleaning and try to cover the head as much as I can, right? Like that, margin convergence, and try to cover the top. Okay, that is the partial cuff repair. Okay, so this 2 years after the surgery. So I found some patients have the better cutaneous, even in the literatures mentioned that the Cutaria will not improve. I found that in subscap it always improve, but supra is not always. Okay, so the healing is pretty good. This is the subscap. You see, it has a belly press, belly up positive, big size tear, really big gap, and poor tissue bodies. I did the partial repair. Okay, for him, and he's satisfied with the result. This is another massive. Okay, we have a lot of partial repair. Okay, this result is pretty good. This is the same. So the survival of partial repair vary from 2 years to 8 years. Okay, I found that most of them after 5 years they will come back again, right? Especially the very old patients. So despite the retear rate, most of the patients satisfied with the 2 years result. So the protocol post-op for the rotator cuff should be slow. If you didn't have your good physical therapist, don't send your patients to the therapist. You don't discuss with them before, you know, because they will torn your rotator cuff. Okay, that's true. You agree, Tony? Yeah, because if you have massive tear and they stretch your shoulder too much, it will torn finally. So the protocol of the cuff repair very slow. I heard that in Korea also very slow, right? They tend to have it stiff because they said the stiff is the process. It was a process of healing. Yeah. If you have stiff, the cuff will not torn. If the patient come back to see you like 4 weeks, they are, oh, doctor, I have good motion, really successful mean surgery. That means it's torn already. You set up stiff, okay, after surgery. So for small size tear, I immobilized for 4 weeks, medium size 6 weeks, for the massive about 8 to 12. Okay, so that's my protocol. So after that, I'll do the stretching exercise to improve the shoulder motion, but I go really slowly, and strengthening exercise in the third phase. Okay. So in conclusion, the good candidate for the repair is that you have good center, okay, you have good cuff and the quality of the tendons. The retraction is not that important. I think the quality is more important. Okay. So the next step, yeah, from the cuff repair, you have nothing to repair. I mean, the top is a very big gap. So even partial repair is so impossible, especially for the patient that have to do revision surgery. Okay, when you come back, there's nothing on the top. So that is another option that's proposed by my friends, yeah, Dr. Mihata from Japan, right? Because at that time in Japan, they have no reverse arthroplasty, so Mihata need to do this superior capsular reconstruction, right? So that's the concept. The concept of superior capsular reconstruction is the static. It's like a spacer, but it is biologic spacer. Block the head from proximal migration, right? So you should have very thick tissue. In Western side, they always using the graft jacket or synthetic. So it failed. They said, oh, Mihata, you're wrong. Why the Western experience failed? But Mihata said, you should have thick tissue, at least 8 millimeters. Okay, 8 millimeters. That is very important because it's act like the spacer. Okay. So this is the indication: irreparable cuff, severe superior migrations, and in the revision cuff surgery. Okay. In Hamada, we prefer in stage 1 or 2. Okay, not more than 3. And this is the clinical outcome. The follow-up result of Mihata is pretty good. Okay. So this is my first SCR after I visit Mihata 10 years ago. He has a massive supraspinatus, but he has good teres minor and the subscap. Okay, you look at the films. See, nothing on the top. Yeah, and the retraction is so far. But he has good subscap and the infraspinatus. Mihata, he performed in decubitus, but for me, it's not easy because I'm the BCheck guy, right? I doing the rotator cuff repair or ACR. I should do it in BCheck position. In vertical, you need to do this way, right? So after I do that, I have my AC joint problem. So I stop because if you're doing this way, your AC joint will be arthritic finally. So I changed the decubitus position to BCheck, okay? But you need to know how to harvest because in decubitus, it's easy to harvest the GT, right? Because you do decubitus. So this is my way to do the SCR, okay? And portal placement is same like you do rotator cuff repair, but lateral portal will be bigger because you can put this graft into the joint. Okay, first we harvest we have two teams, right? One team harvest the graft, one team they're preparing the repair. So the wound is a bit big, it's about 10 centimeters. You need to make it long. So most of the time I need 10 centimeters for the fasciolata. Okay, and the width is about 4 most of the time. But if it's small, I trim a little bit. So this is out the average. So when I make it double. So the length, the size will be 4 by 5. Okay, so that most of the cases it will be like this. Okay, and after that we do the vasectomy cleaning. I think this step is very important because if you don't clean well, when you put the graft in, your suture will tangle and it's like spaghetti, you know. And you cannot do surgery, you need to open. Okay, but I think for the beginners, you can do preparing in scope way, and then you can make a mini incision for graft passage. I think that will be okay because the size is already big for the hole. It's about I think 3 centimeters or 3.5. If you make mini open, Tony, your size is about 5, right? Less than 5. Yeah, I think there's not much difference. So I think for the beginners, maybe you can try the supracapsular reconstruction, combine arthroscopic cleaning, ankle placement, and then you pass the graft by mini open way. Okay, like that. Okay, after you cleaning, so you see that there's a big gap on the top. I clean the glenoid and then put the anchors. 2 anchors at the glenoid, 2 at the tuberosity, and 2 at the lateral low. So that's totally 6 anchors. Okay, for this supracapsular reconstruction, we put anchors at the glenoid. Okay, like that. 2 at the glenoid, and then we do the. This is a very important step. Okay, I modify. I make this side to side. When you pass the graft in, first thing that you have to do is to spread the graft, because if you go like a mass, right? So you need to spread it. So I do the side to side, and also I preparing the suture. I will repair my graft to the supraspinatus also. So this important step, you need to pass the suture before. When you pass it in, you just tie the knot. Okay, like that, and then we put the anchors for the lateral low. Okay. So now we are ready for that. So you see that we have a gap in the middle, and we prepare for the side to side and graft to the legs of the cuff. Next step is to pass the graft in. So I developed the technique we call the double lumen techniques, because you will have the mid proximal and the distal. So your suture can be tangled around and you will confuse. So I make these 2 small lumen, right, in one cannula. So you pass the proximal and the distal that way. Okay. Before to pass, you see, and then you take this tube out and take this tube. This is the 10 cc tube. Okay, like that, and pass the proximal into the joint first. That way. See. Yeah, you harvest to the navigator portal. So we put the graft from the navigator portal. Okay, like that. Put in. Okay. The assistant pull and also your push, but make sure that it's not twist. Okay, like that. So that should be the most important steps. Okay, after that, when you get in, as I told you, you spread the graft by doing the side to side like this. So after you make side to side now, it's like you do cuff repair, very easy. Okay, and also you already pack the suture into your cuff. You just make a knot tying. Okay, like that. See? Yeah, knot tying, proximal and distal. Knot tying, and then side to side, and then we do the lateral low. Okay, like that way. Okay. So same like you do cuff, you try to spread your suture. Okay, front we put in the bicipital groove, and the posterior one I put it close to the posterior cortex, close to the infraspinatus insertion. Okay. So that's the final repair. See? So that the fascia lata tissues and side to side. You see that? And also the end of the graft we repair to the stump of the rotator cuff. Oh, this is the last option for the reverse. Okay, in case you have arthritic change, the patient very old cannot tolerate to surgery. Yeah, I think the reverse also the good option for the patient, right? So yeah, like this, you have the severe retraction, arthritic change. Okay, I think you need reverse one day, Tony. You need to process. Yeah, it's coming. Are you sure? Which company? It's not Johnson, my take. No, it's coming. Register. Okay. Yeah, I think the company that come first will be the millionaire, because I think there's a lot of patients waiting. Yeah. So this indication for reverse. I think nowadays reverse not just the cuff. Most of my patient is the fracture, triple part, fracture sequelae a lot, and neglected dislocation. So these kind of patients, they suffer a lot. For the cuff, I think you inject and they move less, they not airway, that's okay. But for the fracture cases, the patient cannot live. Okay. So most of my cases nowadays, and also the numbers of reverse in the whole world survey, it's increasing, and now the number is more than anatomic shoulder replacement, because the indication, you see, these are the indication, is more extended indication. For the anatomic shoulder replacement, it's for the OA shoulder with good rotator cuff and not severe glenoid deformities. Yeah, you have arthritic chain, you have poor rotator cuff, we prefer doing reverse. You have arthritic chain, you have bone loss more than 15 degrees, we prefer reverse. So that's why reverse becoming more popular. And also the survivorship nowadays, it's comparable. 10-year survival is 93%. Yeah, and I think it's becoming longer. Yeah, you see, that is the survivorship for the reverse. Okay. So this guy, 70 years old, he has a cup-head neuropathy. He like playing golf a lot. Yeah, so he said, "Doctor, please, I want to play golf again." Yeah. So I did a lot of reverse in golfer. It's okay. Yeah, so we did reverse for him, and he's quite happy now. He's back to swing again. But I'm not sure the left shoulder or right shoulder is better. For the left, it should be some problem, right? Because you need to adapt a lot. You tend to have the notching, right? The right shoulder should be fine, because right shoulder for golf is nothing. You play golf? Yeah. Your shoulder is good. So yesterday I just inject into my mentor, my teacher in Siriraj. He's the #1 arthroplasty in Thailand. So his shoulder get arthritic change. You should know him. He's quite famous. So I just inject the visco supplement for him. Yeah. Okay, so this is the take-home message. Okay, so release is important. Yeah, don't jump to repair. Okay, before you do a good release, stop breathing, vasectomy, make sure that it's quite clean, and then you do the repair. And the concept of repair is no tension, tension-free repair. If you make it too much tension, when the patient adduct is torn already, okay? So you need to make sure that when you adduct the shoulder, it's no tension, okay? And cover the top, yeah, as much as you can. Most of the time, you need to do like diagonal reduction or side to side, right? Try to cover the top as much as you can. And the bright partial tear, complete repair, it depends on the patient. If you cannot make a complete repair, don't feel guilty, okay? Because if you try to make over tension, it will be torn. So repair as much as you can, okay? The result is good. If you make a good balance between the front and back, even the top is not complete coverage, that's okay, okay? And don't forget the biceps AC joint, okay? This is one of the most common cause that produce pain after the cup surgery, okay? And try your best to repair, do not give up, okay? So take home message, choose the right patient for the right operation. Thank you. And next year we will have the Asia Pacific. Tony, you also invited. Please bring a lot of Filipinos and Filipinas also to Thailand, okay, in Pattaya, the Sin City. You enjoy. You know, a lot of the big name, the President Isakos, President of Anna, President of Eska, President, all will come to Thailand to this meeting. Yeah, so please come. Enjoy. Save the date. It's on the 29th September, okay, and October. Okay, thank you. Any questions? So before we stop, I have the gift for Tony, my friends, the president. So this is my book I just finished, and Soy also here. He is one of the contributor. So Tony, this one is for you. You're the first one I give because it just finished. Okay. So it's a practical approach on the shoulder instability.
Bancha, in behalf of the Department of Orthopedics, like I said, knowing that it's our 15th year, and that's exactly why we're having this workshop, we're very happy that you've shared this special occasion with us. And with your permission, I will leave this with the department to be one of our department resources, knowing that, I mean, you're a worldwide authority in shoulder arthroscopy and innovative methods in knee and shoulder arthroscopic techniques as well. So thank you very much. Let me just check the pictures because I think it's just you having a good time.